This brief video will possibly be the single most exciting thing you'll ever hear in the workers' compensation space, because we're going to explain how we can cut direct and indirect workers' compensation costs by billions of dollars per annum through an extraordinary, novel method to help people back to work more quickly and more comfortably than ever thought possible. Hello, this is Christine Sutherland, the founder of the F2 chronic pain treatment method used at Resolve Pain Clinics, and I'm delighted to bring you this exciting news along with the proven research which provides its foundation. According to Safe Work Australia, direct and indirect workers' compensation costs are increasing every year, have doubled in the past 11 years, and currently sit at over $61.8 billion per annum nationally. Of this $61.8 billion, employers are currently paying out workers' compensation payments to employees at a rate of $7.7 billion per annum. We're not even talking about all the other costs at this point. Of that $7.7 billion per annum, Safe Work Australia categorises a massive $7.14 billion as long-term payments. This video will demonstrate potential for a highly conservative 50% reduction of costs due to our proven more effective treatment of worker injuries, whether physical or psychological. Nearly 20 years ago, we ran several small trials of our treatment for a number of issues, including chronic pain, clinical depression, and academic and behavioural performance of children deemed at risk. One of these was offered for peer review and subsequently published in a US academic journal. The point is that despite their small size, these trials achieved spectacular results which have not been seen before in the field of psychology. Now, we're well aware that small trials can produce very skewed results, and that's where a particular statistical measure comes in very handy to put these small trials through a kind of trial by fire. There's a measure called the P, or probability measure, and it takes the trial size into account, so effectively you're penalised statistically for having only a small number of people in your trial. If you get a P-score of less than 0.05, your trial is considered to be highly successful in that the method that you've used to achieve outcomes is deemed to be a valid one. The lower the P-score, the more significant your trial results. The P-score in all our trials was far better even than that, coming in at less than 0.001. In the two trials shown here, we did a 2-year follow-up and found that results were maintained even after that period with no further treatment. Our trial with children deemed at risk was done at one of the most troubled high schools in the state. You can see from the chart here that the study group achieved dramatically better results academically and behaviourally. So it's incredibly important to realise that our methodology has applications for just about every psychological problem one can think of, in addition to chronic pain. Now, we've been explaining and using our treatment method for over 20 years, but we're no longer alone. Far from it. The direction of modern research into chronic pain and other psychological conditions is around disruption of conditioned responses, which I'll explain in a moment, in order to extremely rapidly eliminate those processes so that long-winded and expensive CBT or other practices are largely obsolete. There are literally hundreds and hundreds of scientists engaged in research in this area. We really should have been aware of the necessity for a different approach, because we know that for many people chronic pain is not at all like acute pain, and that's why it doesn't respond very well to standard treatment. We know that in many cases there is no difference in outcomes between real surgery and fake surgery. Although some people improve with surgery, some people also improve with the fake surgery, where they are cut and they have stitches or staples, but in fact nothing has been done. Mobility and pain levels don't differ between the surgical group and the fake surgical group. The Australian Medical Journal even published a list of 156 healthcare practices, including treatments for chronic pain, which careful inspection showed not only did not have any positive result, but several of which were associated with worse outcomes. No wonder that some experts say that as many as 70% of people currently suffering from chronic pain are not being helped. Likewise, we see that chronic pain does not correlate with X-ray or MRI imaging to the extent that doctors regard these as useful in precluding existence of tumours and other factors, but useless for diagnosing chronic pain. So what's happening, and why are current treatments for chronic pain so very ineffective? For a start, chronic pain utilises quite different nerve paths to acute pain. In fact, functional MRI shows that chronic pain activity is just like fear activity or depression or anxiety or anger and other strong psychological responses. That activity is not being triggered by the body at all, but is being triggered by the brain in what can only be described as conditioned activity or sets of conditioned responses. You've probably heard the story of Pavlov and his work on conditioned responses. Pavlov was studying the salivation rate of dogs, and he very cleverly noticed that his laboratory dogs would salivate not just at food, but at things which had become associated with food, such as the sound of the assistant's feet walking through the door, or the sound of a tuning tine, or at an electric shock. He noted that literally anything could end up triggering a particular conditioned response. We've seen this kind of thing many times ourselves. We all know that a smoker can be triggered into a desire to smoke by smelling someone else's smoke, or maybe by having a beer or coffee. But a smoker can be triggered into a desire to smoke by opening a newspaper, but not a book, by walking through one door, but not another. It can be anything at all. There are infinite possibilities. And most of us have had a particular sight, smell, touch, sound, or thought trigger us into quite gut-wrenching physical sensations. So it's easy to recognise that conditioned responses can include incredibly strong physical sensations, including chronic pain, and that these sets of stimuli and responses can be hugely varied and complex, and even quite weird and illogical. The good news is that these conditioned responses can now be very quickly eliminated, and people can get relief incredibly rapidly, often in a single session. We achieve that by what I'll describe as precisely messing with the conditioned response. For example, a person might suffer increased pain because there is a breeze or draft, or because the humidity increases, or because they have a particular thought using particular words. We would get the person to focus intensely on that trigger and at the precise same time introduce another stimulus which is quite different. The act of simultaneously triggering two different responses effectively wipes out or extinguishes the unwanted conditioned response and the pain along with it. This is exactly what we've been saying for nearly 20 years, and which modern research now thoroughly validates. If you're interested to gain a more technical understanding, just do a search for scholarly articles using the term disruption of reconsolidation of conditioned responses. There is a massive problem with current treatments for chronic pain, with effectiveness often measured at less than 25%, similar to placebo. Studies showing that CBT is effective for chronic pain have almost invariably been hopelessly flawed, not being blinded or properly controlled. What many researchers have failed to understand and are now being taken issue with is that poorly controlled studies will always show significant outcomes, and so these past studies of CBT have been given undue weight. With better designed trials and more thorough meta-analyses, researchers are reporting poor results that are in fact in decline compared to previous studies. Many therapists honestly believe that they're being highly effective with CBT because the patient seems to improve in their office. However, follow-up shows no change. A medication is considered to be successful if it works for only 30% of people, a rate similar to placebo. Almost every doctor who treats chronic pain patients is well aware that medication is problematic, and it's common to hear their deep frustration as they try to discover something that will finally work for their long-suffering patient. In the case of opioid medications, we know that over time the opioids not only fail to give relief, but actually make the pain itself worse. When the patient is weaned off the opioid, their pain levels decrease. Note the conclusion of the meta-analysis listed here. There are limitations to the success of all the available treatments. None of the currently available treatments eliminates pain for the majority of patients. None of them appear capable of eliminating pain or significantly improving functional outcomes for all treated. We are forced to admit that this is a damning indictment of the state of current treatment of chronic pain, where if people do improve, it's possibly due to placebo effect or just the passing of time, rather than the treatment itself. Our own efficacy rates are outstanding. Over 85% of our chronic pain patients achieve better than 50% reduction of their pain within 2 days. 60% of the trial group were able to completely eliminate or almost completely eliminate their pain. A further 25% were able to reduce their pain level by at least half. We didn't count in our study the rate of those people who reduced their pain by less than half. If we'd done that, we would have claimed an even higher success rate. So what happens when chronic pain isn't addressed early enough or well enough, which is what is happening right now? There are 2 common outcomes that you'll be very familiar with and which every pain specialist knows only too well. First is intensification of the pain. An example of that is a nurse who fell on her back at work, injuring her cervical spine. Not only did the pain not reduce over time, it got much worse, and she had pain not only at the site of the injury, but described experiencing excruciating pain that shot up her neck, into her head and out through her ear, which merges with the next common outcome, which is generalization of the pain and other symptoms to other areas. Someone who's experienced pain due to injury or surgery to the back or to a leg, for example, might now experience terrible burning or tearing pain in the skin of the arms as he or she puts on a shirt. There may even be associated inflammation or swelling as the brain triggers even more activity in the nervous system. Fibromyalgia can be a particularly extreme and bizarre example of this kind of pain. It's important to recognise that both these outcomes lead to completely unnecessary long-term disability. According to our own clinical research and our patient outcomes, we've shown proof that we can readily eliminate at least 50% of current direct workers' compensation payments given the resources to provide treatment, to the tune of at least $3.5 billion per annum. This is the most seriously exciting information we could possibly share with you, because we're talking about direct savings in the order of $3.5 billion per annum nationally, but also indirect savings of many more billions in relation to the cost of disruption to the workplace. At a time when companies desperately need to rein in costs, we should probably be cracking open the champagne at this news. And how are we creating these savings? By enabling people to return to work much more quickly and comfortably than is currently the case, by using this novel treatment methodology that actually works because it has a firm scientific foundation. And of course, we can help avoid many claims altogether by seeing those vulnerable workers earlier in the piece. Achieving these sorts of exciting outcomes is a team effort that won't happen without you. So what do we need from you? If we're to fulfill the potential for massive savings, we actually need to get to work, and that means seeing as many clients as possible, at the same time training and supporting as many other psychologists as possible in order to leverage our expertise. We need for this methodology to be rolled out across Australia and in fact globally as quickly as possible, but also in a quality way that assures it's done skillfully. So what do you need to do next in order to start cutting workers' compensation costs in your organisation? If you've got more questions, please feel welcome to email or phone to set up a discussion. Or you might like us to come and to present to more of your staff or have a Skype conference to address your team and answer their questions. As soon as you're ready, use the referral form on our website at www.resolvepainclinic.com to book in claimants or people who may be vulnerable to becoming claimants. Thank you for listening. I hope you'll join us as a partner in getting this novel and more effective treatment to the people who need it, simultaneously benefiting employers, employees, and the community alike. Let's talk soon.